very good morning to all of you. I warmly welcome everyone on this Sunday's morning for today's CPD program organized by Government Medical Officers Association and Society for Health Research and Innovation. Our webinar link will be open to you from 9 to 9:50 a.m. and no late attendees will be joined thereafter. Each attendee should attend the webinar till the end of the session and to obtain the e-certificate for participation. The CPD points will be given to you, which are strictly adhered to NCCPD guidelines. Anyway, the participation for the e-certificate for participation will be given regardless of CPD points. The link for applying e-certificate will be closed few minutes after the end of the session. The chat box will be open to you for your queries and the answers will be discussed at the end of the session. Also, we kindly ask you to mute your microphone and to switch off the video to avoid any interruption during the session. So now let me introduce today's speaker, Dr. Arunajit Piris, the Consultant General Surgeon from Base Hospital Panadura, to present today's webinar on wound management. This is over to you, sir.
So this is a very important topic in day-to-day surgical practice. Although neglected, I think it is important not only for surgeons and it is important for every medical officer who is doing the private practice. Before discussing the management, I will briefly describe the classification, causes, and then the management. So classification of wounds. This dates back to Egyptian time, where Egyptians were able to differentiate between the infected and the diseased wound from the non-infected wounds. Edwin Smith Papyrus, the textbook of surgery, which was done in 1650 BC, it has described 48 different types of wounds. Greeks may classified it to acute and chronic wounds. Galen was one of the surgeons who managed a lot of wounds in his day-to-day practice. So classification of wounds. For the management purposes, it is very important to differentiate between the acute and chronic wounds, or classified as acute and chronic wounds. In acute wounds, you get, there is a sequelae of events occurring in the process of healing. But chronic wounds, these sequelae, there is no sequelae, but everything happens together. So there will be destruction, degradation, new cell formation, synthesis of mateless proteins, everything occurs together. So there is no balance and it continues to go as a chronic wound. So first I'll classify acute wounds. There are several classifications. So one classification divides into tidy and untidy wounds. Tidy wounds are surgical incisions and injuries which has occurred to sharp objects. Untidy ones are crushing, tearing, avulsion, degloving, devitalize, vascular and multiple injuries, burns and fracture. Those are called as untidy acute wounds. There's another classification which divides into simple, which only involves the skin, and complex, which involves other structures like tendons, nerves, soft tissues, and muscles and bones. Third classification can divide into closed wounds and open wounds. Closed wounds are contusion, abrasion, hematomas, and open wounds, incised wounds, laceration wounds, crust injuries, and penetrating wounds. So classification of surgical wounds. This is one of the important classification which is important in management. So we have clean wounds, clean contaminated wounds, and dirty infected wounds. Clean wounds are the surgical incision and incision with sharp due to sharp objects, where infection rate is less than 2%. So we need not to give any antibiotics in these kind of surgeries, like thyroidectomy, inguinal hernias. We need not to give any antibiotics. Clean contaminated wounds, our appendicectomy wounds we categorize as clean contaminated wounds, where the appendix is infected, but there is no suppuration, no pus, no perforation. So, and even clean bowel surgeries are classified as to clean contaminated wound. Infective rate is 10%. So antibiotic requirement is doubtful. In some patients, it may benefit. So we tend to give antibiotic in these kind of surgeries, especially at induction. Contaminated wounds are trauma wounds with soiling and macerated, multiple lacerations, where the infection rate is about 15 to 30%. So prophylactic antibiotics is again helpful. Dirty infected wounds, infection rate is in some patients it is already infected, like perforated appendix, pus in the peritoneal cavity, so there will be definitive infection, so antibiotic treatment is necessary. So then comes the chronic wound, where we get these wounds. And the acute wounds are easy to manage, but the chronic wounds, it's very difficult to manage. So one classification, you can classify it into spreading ulcer, healing ulcer, callus ulcer. So spreading ulcer, if you can see this, there you can see aggressive edge where there is redness and inflamed edematous, right? So that is, this wound is classified as spreading ulcer. See the next one, which is, you can see sloping edges, nice granulation tissue. This is in the process of healing. This is a callus ulcer or neuropathic ulcer. So pain, unhealthy granulation tissue with indurated edge. If you notice this, that the second toe is bent, so probably the patient is having osteomyelitis, or even there may be chronic stage merely has led into fibrosis of the tendon, causing the flexion deformity of the second toe. So there is a pathological classification. It is important to know this, because in the management it will helpful. It help for the management. Specific ones are tuberculous, syphilitic, actinomycosis, Melanese postoperative, synergistic gangrene, pyoderma gangrenosum. These are specific ones. And malignant ones, sorry. So this is one of the tuberculous ulcer. You get an undermined edge with thicky, creamy pus. So this is Madura mycetoma, where you get subcutaneous tissue infection with a lot of sinuses in the skin. This is synergistic postoperative Melanese ulcer, which has occurred from a herniatomy. incision, right? Next stage is malignant ulcers. So if you see the next slide, you can see rodent ulcer, where the raised and beaded edge. So you may mistake this as a normal ulcer, but it is a malignant ulcer, basal cell carcinoma. So this is, you can see there is a proliferative appearance in the middle of the, or the base of the wound with a raised edge or the everted edge. So this is squamous cell carcinoma. So melanotic ulcers, you get pigmentation in with the malignant features. Then you get the non-specific one, traumatic, like mechanical, physical, and chemical, venous, arterial, trophic ulcers, diabetic ulcers, ulcers due to chilblains and frostbite, recurrent and chronic infections like osteomyelitis. So this is a venous ulcer. This is again a venous ulcers, the greater area and the over the medial malleolus. This is ischemic ulceration, right? So you can see the loss of hair in the toes, and though it is red, there is necrotic in the middle, right? So the fifth toe has been amputated, or the fourth toe has been amputated. So this is a trophic ulcer. So this is a infection. So you may have multiple organisms in this. This is a spreading ulcer. So no, you can't see any features of healing at this stage. This is necrotizing fasciitis. You can't see demarcation. All the skin is necrosed, and the infection is spreading along the fascial lines. So this is also more or less necrotizing fasciitis. So management of chronic wounds. Now, so it is important to get this and the causes of chronic wounds. Then you can deal with the cause, and most of the wound heals with it. Next stage is to make it, and as I said, the acute wounds, there is a sequelae of healing, right? There are several cytokines, so modulated or organized in a manner where the wounds tend to heal. So what you need to do is you have to make a chronic wound into acute wound. Then wound starts healing. So eliminate the cause, improve the general health and nutrition, and local care. So we can divide this management according to these according to these steps. So eliminate the cause, improve the general health and nutrition, and local care. So eliminate, treat the cause. If it is arterial, you may need to do bypass and risk factor management, like stopping smoking. Venous, elevate the lymph, pressure dressings, and surgical management like saprophyll ligation plus stripping or foam treatment, and now laser treatment is also available. Trophic ulcers, you need to offload to get that wound healed. Malignant, you have to widely excise the malignant lesion with the lymph nodes. Radiotherapy, chemotherapy, brachytherapy will help. And specific treatment for TB, leprosy, syphilis in patients with those wounds. If there is a sinus, there may be a reason like foreign body. So we have to take that foreign body, and like perianal fissures has to deal according to the management. Pyoderma gangrenosum, steroids has to be given. General care, improve the patient's nutrition with high protein diet, vitamin A, B, C, and D is important. Minerals like zinc, calcium, copper, ferrous, magnesium is important. In uremic cases, you have to treat accordingly. Jaundice, again, accordingly. Chronic renal failure. Management of diabetes, blood sugar has to be strictly controlled. Radiation, it's basically you can't do much. It's a surgical intervention. Steroids in patients which may be the cause of wounds, so you may have to stop that. Age, you can't change. So local care is divided into or name as time. T means tissue management. I means inflammation and infection control. M means moisture balance. E means epithelial edge advancement. Tissue management. So where the surgeons come in. So repeated debridement is needed in some patients. Slough has to be removed, necrotic areas, devitalized tissues has to be removed, fibrous tissues, sometimes you may have to remove. In chronic wounds, there is a fibrous flow where you need to excise or you have to make it somewhat bleeding as a bleeding flow. So what I do is, which I learned from one of the professors from India, who came when I was registrar to Karapitiya, he tended to put cross incision. He taught us to put cross incision with a 2 millimeter gap until it bleeds. So what happens is from this bleeding vessels, there will be new granulation tissue formation. So we can put a graph later on. So slough, if we don't remove, the body has to remove it. Until it is being removed, the healing process will not occur. So again, the necrotic areas is the same. So we have to surgically remove these necrotic and slough and fibrous tissues. Chemical management or tissue management, hypertonic saline can be used, potassium permanganate, hydrogels, hydrocolloids, collagen, and papod resins. Biological tissue management is done by maggots, which I don't like. I means management of inflammation and infection. So we use iodine, silver, and rotational resins in some patients. And when there is evidence of pseudomonas, we use acetic acid. Local, it's depending on the size of the wound, the percentage will differ. So if it is a large, you tend to use 0.5%. If it is smaller, you can use 1%, and even smaller with heavy pseudomonas, maybe 2%. But I don't use 2%, I use 1% and 0.5%. In some patients where other treatment is necessary, I touch the acetic acid for about 5 minutes and then do the other dressings. Local antibiotic agents like mupirocin and metronidazole is used. Other antibiotics, topical ones are not used in chronic wounds, where you may use in acute wounds, but it's not advisable to use in chronic wounds. And these antibiotic sprays like Multisol is very helpful in acute stage in some, some of the patients. But what happens is when you use it more frequently, resistance develop very rapidly. So when I was pre-intern, I worked in Army hospital where a lot of war wounds and with severe infections. So during that experience, I got this, they had this antibiotic sprays, which had a lot of influence, but when it's come to general practice, even for smaller wounds, these antibiotic sprays are used, and that has made it to the resistance to develop. So now it's not that much effective. So systemic antibiotics is needed in some patients, and aloe vera is also have an anti-inflammatory action. Right. Next one is moisture balance. So we have to cover the wound with ghost dressings, otherwise it will get dried. So people tend to keep some wounds open. I mean, in Sri Lanka, some even consultants advise to keep the wound open. But in my practice, I would say I would like to use ghost dressings. It's in Sri Lanka, it's because it's very hot and humid, and this dust is much more. In UK, when I was in UK, so we never wash the cars, so dust is minimal. So, and the moisture is fairly all right, the temperature is low, so you may keep the wounds open there, but in Sri Lanka, I would advise to close the wounds. So absorbent like foam dressings in some cases where a lot of oozing is present, and hydrocolloids and hydrogels, they hydrolyze the slough, and they keep it moisture with absorbing some of the fluid, and wound kept moisturized. Aloe vera has the same action, and it has smoothing effect as well. In some patients, we tend to use aloe vera, which is, I mean, remarkable outcome is there. And these dressings should be semi-permeable. That is the moisture balance of the wound. This is the third stage of time. E, or the epithelial advancement, hydrogels, hydrocolloids, by keeping it moist, help the epithelialization. In some patients, we need to put skin grafts, and in some patients, flaps. So the negative pressure therapy is one of the advancement in recent time. So I was lucky to go for a wound management program at Germany. So they used to put even small vacuum apparatus which can be put on the pocket and for the wounds. So, and in UK, we used vacuum dressings more frequently. It was done by us. The vacuum were available and the dressings were available. If there is something, some leak, we would be able to get the dressings and repair it. But in Sri Lanka, these are basically in, I think the teaching hospital have vacuum dressings, but we don't have vacuum dressings, and so therefore we have to ask from the private sector to get those things done. And we don't take the responsibility, because when it leaks, you need new dressings, which we may have to, I mean, buy. So the responsibility has given to the drug company for therefore. So we can do a better job if we have these dressings with us and the vacuum machines. So what does the vacuum machines do, or the negative pressure do? It will absorb all this additional fluid, and tissue fluid goes down, therefore the tissue pressure reduces, and so the blood supply improves, filtration improves, blood supply improves, the more oxygen comes to the wound and more nutrients comes to the wound. So therefore the wound tend to heal very fast. So this is what everybody wants to know. So it's difficult because you have to use the trade names, the trade names in all the, so there were some questions asked about this also, but I will go briefly, but I can't say which one is better and which one is not good because it's not correct. And other thing is there is no ideal wound dressing which do everything, right? So therefore, I will briefly discuss this. So because I have seen that people use wrong dressing in wrong patient. So Acticoat, what is Acticoat? Acticoat has got silver and you have a shining surface and a less shining surface. So which can be put every third day on a wound where you need, silver has got antibiotic property. So Acticoat and Atroman both are same kind of dressings, different prices. So done by two different drug companies. So in some patients, Acticoat will be helpful. So Alavin silver, where again the silver is there. Alavin is more of a foam dressing where you absorb fluids, and it is better in where there is a lot of oozing, because Acticoat is not that good in when there is a lot of oozing, because it tend to separate from the wound. Another thing is, if you are putting Acticoat in a oozing wound, you may put another absorbent resin on top of it and frequently change it. One thing more in Acticoat, these silver containing ones, dressings, you should not use normal saline because it reacts with silver. Therefore, you have to use water, either distilled water is ideal. And you have to soak with distilled water for about 2 minutes and soak it and keep it for about 2 minutes, then apply on the wound. And you can keep it up to about 3 days. So Duoderm and Tegaderm foam dressings, especially over the bed sores. So I use these on bed sores, not on the other wounds. So you may use in other wounds, but I tend to use, I use only on bed sores. Idasoap is one of the powder, which is powder form, which is used in in practice. It has got iodine as well as the absorbent properties, very much influence on granulation tissue, as silver, iodine also have some antibacterial activity. So Idasoap is used more frequently. Intrasite gel is where you need some desloughing to occur. And the Idasoap can be used in large wounds where you need to put the powder just like just you don't have to feel, just equally spray on the wound. So Idasoap packet can be used in several times, and but intrasite gel is a gel, so it cannot be used like that. So you can use it in smaller wounds where you need desloughing, but in larger ones, definitely surgeons has to get involved. So this is one of the desloughing agent. And Metrogel, keeping the, when it is gel, you keep the wound moisture, and Metrogel has got hydrocolloids, which has potential to influence the granulation tissue, and it has also got metronidazole. Offsite spray, it's offsite spray and waterproof dressings. Offsite waterproof dressings are there. This is basically used on surgical wounds. and not in chronic wounds. Hydrocolloid and hydrogels, again, they have these particles or the contents which I can't remember the names. They have catalytic effects as well as absorbent effects and keeping the wound moisture and influence growth factors. So therefore helps in wound healing. Biofilm also have it's a powder form against the particle forms. It has got catalytic effects as well as absorbent effect, and there is antibiotics. The antibiotics present in biofilm are mupirocin and metronidazole. So in some wounds, infected small wounds, biofilm is important. Aquacin, again, it's spray form. It says that it has got hydrocolloid and hydrogel properties. So once I used, but I didn't see much improvement from the wound healing property in that, but it's only I used in few patients only, so I may be wrong I can't comment much more on aquacin. Oxaferin used for long time, it has regenerative power and it has also got all these powers. And Pontosan is a new one which is used at Kalutara, and the Kalutara surgeons say that is very effective. But so recently I started, so only just started 3-4 days back. So I can't still say much about Pontosan. Right, that is end of my presentation or the lecture. So we can open up the discussion. Before this, long time back, which was given long time back, all acute wound doesn't need antibiotics, true or false? Yes. So all acute wounds doesn't need antibiotics is false, because in some you need antibiotic, like clean, contaminated and dirty wounds. In all chronic wounds, antibiotics is compulsory, again fall. So some patients in only local treatment, antibiotic may not be necessary. By definition, wound lasts beyond 3 months are classified as chronic wounds. It's 3 weeks, but various books says, describes the time period is different. So if you see several books, you see the period, but 3 months is long. So 3 weeks to 6 weeks, I would say. Steroids delayed healing in all wounds. False, because in some patients with pyoderma gangrenosum, the steroids is the treatment, and where there is vasculitis, steroids help. In eczematous wounds, steroids help. Ideal wound dressings can be purchased in some developed countries. No, it's not available at all. Okay. All right, then the questions given to me. Are we going to open up the discussion? Or? So these were the questions given to me. What is the best imaging method to exclude osteomyelitis? So I'm not an orthopedic surgeon, but I would say, the experience I have during my orthopedic training period. So ESR is one of the important investigations to find out the active osteomyelitis. White cell count, ESR, X-ray findings of lucent areas with sclerotic edges and periosteal reaction will be you can see in X-rays in osteomyelitis patients, and CT and MRI is more helpful. But to answer these questions, which best imaging method is the radioisotope scan is the best imaging method to exclude osteomyelitis. So second questions, types of wound management. So I have already discussed, I think. How to differentiate bacterial colonization and infection. So it's very difficult. So you, if you take a swab from the surface, this may be the colonization. So you have to take a tissue culture to get the infective organisms than the colonization. So venous ulcer management is a separate topic. I think it's very, it's not time is not enough. What is the time now? 10:15, 10. Yeah. So we have to have some discussion. It's a separate topic. I will briefly describe venous ulcer management. So you have to do a duplex and find out the pathology of the venous system, exclude DVT. Saphenofemoral incompetence we need to ligate and divide, and if a Bownie perforator is there, we have to do the stripping. But most of the time it's not commented on the Bownie perforator, so I tend to do stripping in everybody. And if there is perforating incompetence, you need to stab valves or subfascial ligation, and or sometimes you can inject them after after dealing with the saphenofemoral ligation. And so nowadays foam treatment is available. So basically some general surgeons do, and basically it's done by vascular surgeons. And the laser treatment also some general surgeons do, and managed by vascular surgeons. If there is saphenopopliteal ligation, we have to do the saphenopopliteal incompetence. We have to do saphenopopliteal ligation. So if the patient have both, the surgery we can do the surgery at once, or we can do it as stepwise as well. And if there is deep vein thrombosis, the saphenopopliteal ligation or treatment of superficial veins, veins are contraindicated. So other thing is to have graded pressure bandages. So we tend to use 4-layer bandage. But when you are doing the 4-layer bandage, the wound has to be, pretty healthy. Otherwise, if it is there is infection, oozing, and 4-layer bandage is given, so you keep it about. Some surgeons keep it for about weeks. Some do keep it for about 2 weeks, and depending on the wound environment, you may have to adjust the time. And when there is fibrosis of the wound and there is no edema, but there is edema of the upper part, but around the wound is all fibrotic, you can't compress. So in these people, compression bandage may not help. So that is, and the skin anti-inflammatory or the steroids has to be given. Topical steroids has to be given when there is evidence of eczema, and the surrounding skin we have to manage surrounding skin, we have to keep it moisturized. So moisturizing creams will helpful. And olive oil is one of the ingredient we use. And right. So you may ask any questions if regarding this, if I forget anything, right? So venous, that's venous ulcer management. And betadine is, when we have a venous ulcer, I don't use betadine because I have seen it's there is allergy for betadine in these people. Management of non-healing chronic wound in lymphoedematous leg. So it's a very difficult task. So I had one patient with chronic lymphedema and a wound. He was a Down's person at 40 years. So somewhat mentally subnormal. So, but I kept this patient in the ward until the wound heals with the elevation. Purely with the elevation, you may have to do a wound toilet once and antibiotic if there is any evidence of infection, and then just elevation because lymphedema, I mean, nobody does any kind of surgeries. If we need to do surgery, you can do lymphovenous anastomosis, which is not done, though it's described. It's not been done. So that has to be done by the vascular surgeon, I would say. How to, all right, options of antibiotic resistant in resistant chronic wounds. The rotational dressings is used in these kind of patients, right? So I use hypertonic saline, betadine, acetic acid, and Milton solution in some cases. When there is venous insufficiency or eczema or evidence of betadine allergy, I just use the hypertonic saline and hypertonic saline as well as acetic acid. Types of wound dressings already discussed. Does it mandatory to exclude the necrotic skin over the wound? So yes, in most cases you need to remove, but in some patients where small necrotic areas, it's not needed. You may use something like iodosob, not iodosob, Intrasite gel. And in like vascular patients, peripheral vascular disease, then you may leave the necrotic areas for body to demarcate and these stuff, because if we cut along that margin, there will be another area of necrosis. So in vascular in arterial insufficiency or the peripheral, in patients with peripheral vascular disease or ischemic limb, you tend to leave it. If you have a wet gangrene, then you may have to involve, try to make it that dry gangrene and then leave it alone, and get the vascular surgeons involved in further management. May I know the newest material available in Sri Lanka? So discuss indications of primary and secondary closure, rationale behind closing a dressings and dressing change, right? So another important topic where it's not being done correctly. So when you have infected wounds, you leave it open for secondary suturing, right? It's usually done after 48 hours, but in some cases may not be possible. In some cases, you may do it if it is fairly pretty clean in 24 hours, but normal time is 4 days, 2 days to 3 days. So the wounds which we do secondary suturing are, or the cleaving opening, are the infected wounds, perforated appendix, and contaminated dirty wounds. And when there is fractures, compound fractures. So what we were advised by my orthopedic surgeon or my orthopedic boss is to, when you have a compound fracture, you open up the wound a little bit more and do a thorough washout, clean it with normal saline as well as betadine, and then you may close the part you have opened, but leave the rest of the wound for it to settle. But in some cases, if the wound is pretty clean, we tend to close the wound. Right. Right. Is it open? Or any questions regarding this, or in between, or so far discussion so far?
Yes, sir. There are a few questions in the chat box also. May I ask them?
Yeah.
In divisional hospital where only soframycin is available, is it adequate for local application?
Yeah, in acute wounds, yes, not in chronic wounds. Acute abrasions, I mean, even antibiotic is not necessary, but we tend to apply locally. But in eczemas, you should not use, but it's adequate because, I mean, so in these kind of patients, we usually, even antibiotics may not be necessary. So soframycin is enough, because if you give further like fusidic acid and mupirocin, then the resistance will develop, because these will be definitely used more frequently ultimately, and ultimately their effect will go down.
Then, sir, what is meant by rotational dressing?
Rotational dressings already discussed, I think. So daily dressings are being done. So the ingredients used is hypertonic saline, 0.5 acetic acid, Milton solution, and betadine. So alternatively, you do, if you use betadine today, next day will be hypertonic. I mean, it could be even Milton's, whatever. It has to be in a rotational manner. So the environment is not healthy or the suitable for the organisms to grow. So that's why you are using, and these ingredients will have separate qualities, so help in infected wounds.
What can we use for unhealing venous ulcers? Even 2 to 3 times SFL surgery also done.
So there may be, yeah, so you also have seen this kind of patients. So there may be additional channels, or there may be part of deep vein thrombus. So what, if you get a patient like that, I usually do another duplex scan and even get the vascular surgeon's opinion. So in this kind of patients, if there is no recurrence or you can't find anything, then we can isolate the veins, which small veins, and then you can inject those things with STD and even foam treatment, and even local laser treatment can be done for these small ones. And if you can't see that also, only edema, there may be, I mean, during the surgery, you may have damaged the lymphatic system as well. So when you are doing a saffron femoral ligation, my boss, Dr. Kollure, asked me to put a 1 centimeter, 2 centimeter incision and do it without cutting these lymphatics. So I was SR to Dr. Kollure. So that was his advice. So not to damage any lymphatics around the vein. So no one put big cuts around the saphenofemoral, so around the saphenofemoral junction. So better if you have, I mean, patient like that, then the compression bandage is the treatment option for layer bandaging. Right.
When to use Papo and aloe vera and how?
So Papo I have used in several patients, but I have seen worsening effects also because these Papo dressings, you have to prepare it properly. You have to scrape it. So these once the scraping technique is not aseptic. So you may be introducing new organisms. So I use very sparingly. And so when you need proteolytic activities where you can't do surgery, where especially on tendons and important structures, then use Papo dressings. But again, I said I have few bad experience, so I don't use it much. So aloe vera, so there were several cases. These kind of wound dressings were done, and so we have referred to dermatologists also. Their opinion was also done, and this wound didn't heal at all. So I have used aloe vera in these wounds. So very good results. So I mean, somebody should go into aloe vera and find out, oh, you have to make a wound dressing from aloe vera. You can't say this is Eastern medicine. In Germany, all these things are used. Even honey is used. So bee honey is used. There are wound dressings which impregnated with bee honey. So I mean, so therefore, somebody has to, go through this and do study on this and then present it, and it will definitely the patients will benefit from it. And it also have a smoothing effect. So when I have seen it is catalytic effect as well as good granulation. There is one patient at the moment in the ward. Now she's there for about 2 months. So at Panadura, we tried everything. We did wound toilets repeatedly. Each time there will be there is another necrotic margin, and then ultimately I used aloe vera dressings, and then this has stopped. So we had to do two more wound toilets or the necrotic wound debridement. And then now she is in a recovery space. Still, I use aloe vera on that patient.
So what is your opinion on Multisol spray, which contains polymyxin B, neomycin, and bacitracin, used for chronic wounds?
Yeah, as I said, not suitable in chronic wounds. It is suitable in acute wounds, in the hospital settings where acute wounds which has become chronic, like largely so due to infection. So I am using that, but now not much effects like in the past. I have the experience I had in the past because this been used everywhere. So keep it for a valuable. The valuable means not the VIP. It's the valuable means the patient who needs it. So, and I think it's as a aerosol. It is CFC, the ozone layer destructing mechanism in that. So that's why it was banned once.
So what is the best wound dressing for deeply infected episiotomy wound?
I'm not the gynecologist to answer that. So wound toilet, the wound debridement has to done, right? And then so this kind of acute wounds you can't use. You may not be able to use like these iodosorbs and hydrogels, and because it won't go in, so these are deep wounds. So the betadine and hypertonic saline alternatively will help, I think, I would say.
Then, so what is the emergency management of acute bleeding from varicose veins?
So just press on the vessel. So just keep, I mean, even finger pressing or small, if you put large dressings, it won't compress the vessel. So we have to put a small dressing or a compression dressing, and then the crepe bandage over it. So, I mean, when you do angiogram, you just keep I mean, a small soap, roll soap on the artery, so that will stop bleeding. Even the artery, it's a small dressing only. I mean, it's likewise in venous, definitely not you don't need not to have that much of pressure. So you just compress on the vein, on the bleeding point, and then put a bandage from lower down upwards, or the use graded stockings.
It has been asked that to mention some words about honey dressing. I think so mentioned that.
Yeah. Okay.
Then in private practice, what is the best management procedure in acute and chronic wound?
I think you
Short
can't
words.
answer that, no. So you have to go through. I mean, that's why I gave this lecture. So it's the lecture is the answer for that, I would say.
Then, so please the management of recurrent cellulitis.
So after three episodes, so if the patient is diabetes, you have to treat diabetes. If the patient is having renal failure, you have to treat accordingly. And so if the patient has a chronic lymphedema, then you may have to have a compression bandages, right? Saphenofemoral incompetence you have to treat. So you have to treat the cause first, and then if there is no cause as such, then I would say prophylactic oral penicillin is given after 3 episodes, some after 4 episodes, some tend to give after 3 episodes. Right.
How to prepare hypertonic saline?
That I don't know.
Yeah.
Okay.
So regarding the prevention of bed sores in fracture patients, any special comments on that?
Yeah. So you have to use these water mattresses and air mattresses, and frequently change the position some can say that the patient is so there is traction, the patient cannot be moved, but say patient can be sit up, patient can sit up, then the bed position, these beds are usually can be adjusted, the position of the bed can be adjusted. And so nowadays these traction methods and plaster casts, immobilization, bed bound or fracture neck of the femurs, and rotational boards are still used, but ideal is to have internal fixation. Even I would say for old age also, it's better to have a fixation, because to prevent these complications. Right.
Which factors need to be considered while changing of dressings, daily or every other day, like that?
Yes, daily dressings is needed when there is infection, when there is a lot of oozing, right? So then daily dressings is needed. And if I mean, it's when minimal sloughing, you may change it every 3rd day and the infection is very much less, then we can do it every 3rd day. Otherwise, in most of the patients, it's every other day dressings. I forgot one of the questions given before to answer. I forgot to answer that how frequently in a surgical practice you need to change the dressings. So the dressings done in the theater is very sterile. So better to keep it for about 4 days. So then change it. So after 4 days. Then after that, every third day. So sutured ones, or otherwise you can you may use some oxide spray and then just dressing over it, and then you can observe next day, or the I mean the outer dressings can be changed to see whether there are any infections. But in other, I mean, that is not in normal practice. You don't use oxide spray now; it's not available also. So every daily dressings in infected and oozing wounds, every other day dressings in normal practice, every third day dressing in patients where I mean the less oozing, less infection. And normal, I mean the sutured wound, it's every fourth day, thereafter every third day. And this suture removal also we have seen, I mean, the in practice, it's not what I mean. So sometimes inguinal hernia sutures is kept for two weeks. It's not correct. It has to be taken off after 7 days. And neck and face even in 5 days. In face, you even can, if there is no tension, take the sutures in 3 days. Scalp scarring is not a problem, so you may keep longer time. On the other hand, scar heals very quickly. Even 24 hours in some wounds, it heals. So if there is tension due to occipitofrontalis muscle cut or deep fascia cut, then you have to keep it for about 10 to 14 days. Otherwise, it's only needs to keep for about 5 days. And so 7 days practice is all right for the scalp because its scarring is not that problem. So all these the brain surgeries, they keep for about 10 to 14 days. Palms and soles, you have to keep for 14 days. Midline laparotomy incisions, it's about 10 days. And rest of the limb wounds, it's 7 days is the principle. So dressings change also. I mean, when you do 4 days, 7 days means after removal of sutures, you may put us in the dressing and can take off after 24 hours to 48 hours. Then you can leave it open.
Finally, sir, when using aloe vera, is whole leaf taken crushed?
No. So the surface part has to be removed. Then you can scrape it with a spoon, right? So that's so basically, if the spoon is sterile, so inside the plant is sterile because there is the outer covering is taken off. You can't stay sterile, but less likely to have microorganisms. That's why I prefer aloe vera than Papo, because Papo has got proteolytic activity, but the preparation may not be good.
Okay, sir. Thank you very much.
Yeah, one more this thing in the previous questionnaire. So there was somebody has asked about the tetanus prophylaxis and wound management and the place of steroids. So steroids is, as I said, given in pyoderma gangrenosum, vasculitis, and where there is eczema. And so how often need to review or often to change the dressings, as I already described. I mean, in patients where you have sutured in a suspicious infected case, then you may open it after 24 hours. It's all right. So it has to be, there is no strict rule. So, so if you are thinking of infection, if you have a spiking fever, you need not to keep for about 3 days or 4 days, then you may open up and see whether there is evidence of skin infection. Please touch on the so one question was, please touch on the tetanus prophylaxis, how to clean and wound properly and agents used. So tetanus prophylaxis, there is something immunization program is there. So can we go back to the slide and is it possible? So this is one of the protocols. So infant 6 weeks, 10 weeks, 14 weeks, 18 weeks. I really don't know and the 5 years, then the boosters are given every 5 years. And but it is infant 6 weeks, 10 weeks, 14 weeks, 18 weeks, and 5 years. After that, boosters are given when there is road traffic accidents, severe burns, crush injuries, and war wounds. But if you have been immunized within 5 years, I mean, it's not really necessary. But people can't remember the immunization. So in a trauma, in a wound, so we tend to give tetanus prophylaxis. But these schedules may be wrong, so you have to go with the immunization schedules, right? Which I couldn't do during this period because I saw this yesterday night. So this is one of the schedule I had from my old notes. Right? And the other part was how to clean and wound properly and the agents used. So preparation will be in a surgical setting. Preparation, not really the answer for this one, is we use betadine to scrub, and so some use betadine as well as surgical spirit. And if you are using this, you need to keep surgical spirit is used first and then the betadine. So if you are using surgical surgical spirit, then you have to keep it about 2 minutes. So we don't wait for that. We just wipe it surgical spirit, then over it betadine, and then both get diluted. So I would say one ingredient or the solution is enough. So we use betadine and then keep it because it's have a layer on the skin until you do the surgery, and end of that you washed out. But in allergic patients we should not use, and then you may use surgical spirit. And if you are using surgical spirit, you have to clean up the flexure creases because this can burn the skin, right? So that has to be cleaned up before dressings. Well, sorry, clean up and drape in the patient. So wound wise, you have to wash with normal saline, and then you may wash with betadine, especially in compound fractures, and even other wounds you may wash with betadine. And so if like a nail prick injury, you may have to open up, put an incision either side, and do a washout. And in compound fractures, as I previously described, you may have to open up a little bit more and then wash out, and then suture the what you have open up. But in like a nail ones, you just leave the wound open. And this tetanus is a what I can remember is a microaerophilic organism. So better to have open up wounds in when you are suspecting, when we think about in future tetanus. And so in these kind of patients, hydrogen peroxide also helps to wash out the things, and there is oxygen generation or H2O2, which help in lysis of these organisms. Right. Okay.
So there are two other questions.
Okay.
If a patient had a contaminated laceration which occurred 2 days before, present to the hospital with the secondary bleeding, what will be the next management?
Right. So, compound wound, sorry, sir, again, it's a
Contaminated
contaminated
laceration.
wounds. So we have to do a wound debridement in this patient, definitely. And if there is bleeding, you can surgically manage, right? If there is infected areas, you have to remove those things. So if you have necrotic areas, doubtful areas, then you have to remove those things and do a proper wound toilet. And then if you have a proper wound toilet and there is minimal infection, you may close the wound. Otherwise, leave it for secondary suturing. That is, I mean, as we are surgeons, we can say this, but in private practice, I would say you wash out and then give antibiotics, and then don't suture it, and then after 24 to 48 hours, look at the wound again, and if it is pretty clean, you may suture. And primarily, you may put a compression bandage on the wound.
So what about the management of skin grafting wounds?
Management of skin grafting
Wounds.
Yeah. So skin graft wounds inspection is done on day 4 and day 5. I use day 5 in some patients, day 4. I keep this paper if the grafting is in lower limb. I keep in the hospital for until the first inspection done, right? Because when they go home, they keep the leg down and there will be oozing, and that will push the skin graft out. So better to keep the patient in the hospital and open up after 4 days. So after 5 days. So then the second dressing is again done with a Vaseline gauze, and so hypertonic saline or normal saline is used. So first thing, and even betadine, soak betadine, squeezed up, and then you may apply orovascular dressing if there is no evidence of allergy. Then after 5 days, next inspection will be in 3 days. So you may need to put another dressing after that, means 8 days, and then by 2 weeks it should taken up, and the donor site is inspected after 10 days. But when there is bleeding, or by 10 days this should heal. If it is not healing, that means you have to take a deeper graft. So that's why it's not healing in 10 days. So then you may apply some antibiotic creams over it, because these are more or less acute wounds. So then soframycin or whatever available is all right. Then the skin graft site wise, it's in 2 weeks it should heal. But I mean, you know that only part is taken up in some patients, and then you may need to readmit the patient. And then if there is necrotic skin, you may have to carefully remove those things, and then manage the wound as previously. Right, that would answer, I think. Right. Any more questions?
No.
Right.
So this is the end of the session, and I thank you very much, sir, for your excellent and very informative lecture on wound management, which is a very practical topic in surgery. So you can all the participants can find the link for e-certificate from the chat box, and we appreciate your feedbacks also to improve our future webinars. This lecture will be available to you via Sri YouTube channel in couple of days, and you can go through it again. Finally, I thank all the participants for joining with today's session also. Thank you.
Thank you.